Hi, my name is Kevin Chavez and I'm going to talk about acute kidney injury in patients with cancer. Definition: Patients with cancer are the highest risk for infection, sepsis, tumor lysis syndrome, drug-associated toxicities, and other comorbidities that significantly increase the likelihood of developing acute kidney injury (AKI). The development of AKI in these patients represents a significant event that increases mortality and morbidity, can be limit the effectiveness and use of chemotherapeutic regimens. Unfortunately, no effective therapies for AKI exist, making prevention critically important.
Acute kidney injury, or AKI, is when the kidney's not functioning at 100%, and that decrease in function usually develops relatively quickly, typically over the course of a few days. Actually, AKI used to be known as acute renal failure, or ARF, but AKI is a broader term that also includes subtle decreases in kidney function. AKI can essentially be split into three types: pre-renal AKI, meaning the cause of the kidney injury is coming before the kidneys; post-renal AKI, meaning after the kidneys; or intrarenal AKI, meaning within the kidneys. Now, the kidney's job is to regulate what's in the blood, so they might remove waste, or make sure electrolyte levels are steady, or regulate the overall amount of water, and even make hormones. The kidneys do a lot of stuff. Blood gets to the kidneys through the renal artery, into tiny clumps of arterioles called glomeruli.
Applications in medicine. The long-term consequences of AKI in the patient with cancer are highly variable, and it is likely that overall severity of illness, age, and functional status contributes significantly to prognosis in this type of patients. Patients with hematological malignancies, including leukemia, lymphoma, and multiple myeloma, are at the highest risk for AKI development, in most cases serious.
This is Doug Brunk for Global Medical News Network, reporting from the annual meeting of the American Society of Nephrology in Denver. In what is believed to be the first study of its kind, researchers from MD Anderson Cancer Center evaluated the incidence, risk factors, and outcomes of acute kidney injury in cancer patients.
We know that acute kidney injury is on the rise, but little is known about its incidence or outcomes or risk factors in patients with cancer. So we, working at MD Anderson Cancer Center, looked at admission of patients into the cancer center over a 3 months period in 2006. We found that the incidence is much higher than compared to the community admission of patients for medical reasons. Cancer patients had about 28% acute kidney injury during the hospitalization. That included 14% who had when they were coming into the hospital, and 14% who developed acute kidney injury while in the hospital. Again, little is known about the outcome of these patients who developed acute kidney injury. And what we found was that patients who develop acute kidney injury, the cancer patients in the hospital, has about 5-fold increased odds ratio for mortality. They're all 3 times more likely to stay in the hospital as well.
Pros and cons. Pros: various diagnosis methods better result in rapid diagnosis. Cons: the increase in cancer patients with kidney disease is related in part to the high incidence rates of many malignant tumors, increase the length of hospital stay, and lower rates of complete cancer remission. No effective therapies for AKI exist.
Kidneys ensure that the body fluid levels are regulated and that waste products and toxins are effectively removed from the blood. Acute kidney injury, or AKI, describes a rapid decline in kidney function over a period of days. AKI is usually diagnosed based on a rise in creatinine, a serum marker of kidney function, or a fall in urine output.
Issue applied in Ecuador. It is necessary to know about specific risk factors, modification of risk and careful adaptation to rapid AKI diagnosis are critical for improving outcomes and the lifestyle in Ecuadorian patients with AKI. In conclusion, dramatic advances in the care of patients with cancer have occurred in short periods of time and have led to demonstrable increase in longevity. However, a consequence of these advanced therapies has been the occurrence of AKI in many forms. Rapid recognition of AKI as well as appropriate therapy is critical to sustain the gains in outcome associated with novel chemotherapeutics. Increasingly, AKI etiology in patients with cancer have become more complex and multifactorial. There should be focus on AKI prevention as AKI has the patient to significantly worsen outcomes and limits available therapies for cancer treatment.
Acute kidney injury is the most frequent complication in patients with septic shock and is associated with high mortality. Patients with life-threatening complications from acute kidney injury typically undergo renal replacement therapy on an urgent basis. However, in critically ill patients without life-threatening complications, the optimal time for initiating renal replacement therapy remains controversial. In this randomized controlled trial, 488 patients with early-stage septic shock and severe acute kidney injury were assigned to undergo renal replacement therapy either early, within 12 hours after the onset of acute kidney injury, or after a delay of 48 hours. Acute kidney injury was defined by the failure stage of the rifle classification, which includes oliguria, anuria, or a tripling of the baseline serum creatinine level. The choice of the renal replacement therapy technique was at the discretion of treating clinicians at each of the 29 participating intensive care units in France.